I'd like to invite our next speaker, Dr. IKEDA Lal, a good friend. She's going to be talking on radial keratotomy and post-transplant eyes, getting better biometry in the most challenging cases.
Course. I'll be talking about radial keratotomy and post-transplant eyes today. Now let's understand the basic principle how radial keratotomy works. We have radial paracentral incisions. They cause paracentral steepening and a central flattening. This flattening actually occurs in a very small central zone, and that's how RK is different from LASIK. We have a smaller central flatter zone, typically 3 millimeters or less. And this surgery significantly changes not just the anterior corneal curvature as well as the posterior corneal curvature too. We have surface irregularities. There are areas which are steep and areas which are flat, and this leads to irregular astigmatism. We have all of these factors which ultimately land up in higher order aberrations and poorer quality of vision. These patients also have hyperopic shift over the years, and these are all the challenges that we face. What really happens when we are planning an IOL power in these cases is that we have overestimation of the keratometry because a lot of keratometers as well as topographers measure the values in 4 millimeter zone, and here we have a very small central zone. As a result, we'll end up overestimating the keratometry, and third generation formulas would lead to underestimation of the effective lens position, and we would land up in a hyperopic refractive error. There are various IOL power calculation formulae which have been used for post-RKIs. This is one of the papers published in Ophthalmology 2020. And what they found was when the refractive history of the patient is available, we have the Barrett-Truquet, which works well. And when the refractive history is unavailable, we have variations of Barrett-Truquet. Without the history also, we can calculate with the help of the ACRS calculator. And that works, that in this paper, it was found that that works as well as the standard Haigis formula. Here they found that the double K holiday based on the IOL master and the Potman Hill based on Pentacam were less reliable than any of these. So before I talk about a couple of cases and really try to understand which formula to use, just a word about the ASCRS calculator. We have to select the prior RK module here, and a few of the important points that we need to keep in mind that the target refraction that we enter for these patients has to be slightly myopic and not emmetropic. This post-RK data that we have to fill should be the most hyperopic refractive error that the patient has, because this would account and correct for the hyperopic shift that these patients experience, and also the myopic shift that can happen due to nuclear sclerosis once these patients develop cataract. So ideally, this refraction needs to be before the patient has developed cataract. Then we need to fill in this value of the Pentacam. This is from the sagittal curvature map, the mean keratometry value at the 4 millimeter zone. So how do we decide what target myopia we should fill in the ACRS calculator? It could range anywhere from 0.5 to 1.5 diopters. And what are the factors that help us decide this? First is the number of incisions. If we have a 4 incision RK, we are probably okay just filling in 0.5 versus a 16 incision RK. How regular these incisions are, if they're associated astigmatic keratotomy, then we would probably aim for slight myopia towards 1.5 diopters. And also the present refraction of the patient would affect our decision, along with the distance from the center, how small the central zone is. Smaller the central zone, we need to aim for slight myopia. So let's look at a few cases. The first patient is a 69-year-old male who has undergone 4 incision RK surgery 25 years ago, and now he's planned for left eye cataract surgery. And we see here that actually the topography looks pretty regular. The thickness is not too altered. And when we do a look at the pre-cataract workup and compare the distribution of the power in the Pentacam as well as look at the optical biometry, we see that the astigmatism is corresponding here. And we need to look at the axis of astigmatism more than the magnitude. If we have axis of astigmatism which corresponds within 10 degrees, probably this is a good case to plan a toric IOL for, especially if we have repeatability of these readings. Then we fed in all the data in the ACRS calculator, And here is the result. So we went ahead with 23.5 diopters of final IOL power. And if we had used Haggis, we would have also selected either 23.5 or 24 diopters. Now, a second case has undergone 8 incision RK about 30 years ago. And look at this topography now. It's much flatter than the earlier case. And what is interesting for this patient is that he's still myopic, even though he's undergone radial keratotomy. So here, when he's still a myopic, we need to look at the axial length when we are looking at the IOL power calculator. And this is the lens star printout as well as the IOL master. And we see that the axial length is 30.76. And that's how the IOL power that we are getting is more myopic. So we have to correlate all of these factors, the patient's present refraction, the axial length, as well as the IOL power that we are getting on these formula. So again, we use the SCRS calculator here. And the result shows us that anywhere between 13.98 to 16.43 in different formulas the patient should do well. We have kept an offset refraction. Target refraction has been aimed at -1 diopters here because he has undergone an 8 incision RK. So we finally decide to implant a 15.5 diopter IOL for him. We can look at the incisions here. They are pretty regular. Here we are more likely to have a preferable outcome than when the incisions are quite irregular or associated with astigmatic keratotomy. So here the points to take away from this case are that if the IOL power is less than 20 diopters, then we must cross-check the patient's refractive error. If he's in high myope, look at the axial length. And this is the post-op refraction of the patient 2 months down the line. Now, a third case here is a patient who has undergone a 32 incision RK. He's a scleral contact lens wearer, and his earlier refraction is still hyperopic with a significant amount of astigmatism. And we look at the keratometry here, we can see how flat and irregular this cornea is. So definitely this is not an ideal case for us to plan toric IOL. He's already a scleral contact lens wearer. And when we look at the optical biometry, we know that these readings are not accurate. When we look at the keratometry here, we are way off than what we are getting on the topography map. So here, using the values from the pentacam, which would be better for us and would give us a more accurate result as compared to the optical biometer. So this is what we do. This is the mean keratometry value. And when we feed it into the ASCRS calculator, look at the difference here. The IOL master, the lens star, is giving us a completely different reading from the pentacam reading. But if we had missed all of these findings, if we had not looked at the topography, we would have landed up in a absolutely very gross refractive error in this patient and a huge hyperopic surprise. So we implant a 29 diopters of IOL here, and this is a refraction at 1 month post-op. So to conclude about the post-RK cases, target refraction should be always aimed at slight myopia. Using the ASCRS calculator is very effective, but we have to also analyze the topography and probably look at the flattest keratometry value that we get. If the keratometry is more than 40 diopters, we have to keep in mind that this could be a paracentral reading and might not be accurate. Now, I'll talk briefly about the post-transplant cataract surgery. The first question is, when do we take up a patient who has undergone corneal transplant for cataract surgery? Preferably 1 year down the line when all the sutures are out, but it is not absolutely essential for us to plan these cases after all the sutures are out. Even after the sutures are in and we have done a topo-guided suture removal, we have to wait for 2 stable topographies, and if we feel the topography is stable, then we can still go ahead with cataract surgery. And a topography is a must before taking up these patients for cataract surgery. We have to look at the surface and see how regular it is. Evaluation of astigmatism would help us decide what kind of IOL we need to implant in these eyes, whether it is regular or irregular. So how do we choose the IOL? When we are looking at the astigmatism, when we look at the topography, if it is regular, we could think of using a toric IOL. If the patient is a RGP or a scleral lens wearer, then we have to absolutely avoid toric IOLs because it's very difficult to correct an astigmatism that has been corrected at the IOL plane later on. Toric IOLs are useful when the astigmatism is regular, when the topography is stable and it is repeatable. In a full thickness penetrating keratoplasty, I would avoid multifocal IOLs, but we can plan multifocal IOLs in patients who have undergone DSEC or DMEC. So I would just show you a small video of this patient who had an astigmatism of 5 diopters after corneal transplant. She has undergone a full thickness keratoplasty 3 years ago. So here we have planned a toric IOL, and we can even use customized toric IOLs for these patients, and they work really, really well if we have a high astigmatism. So I'll skip through the video in the interest of time. And I would just like to end with a few salient points. About IOL power calculation in post-transplant eyes is lack of data for us to clearly understand how to plan these cases. But what would help when we have a full thickness graft is to always target 1 to 2 diopters of myopia. Post DSEC eyes, we can expect again a hyperopic shift, expect 1 to 1.5 diopters of hyperopia and adjust accordingly. Post DMEC, we would probably not expect that much of a hyperopic surprise, and just targeting 0.5 diopters of myopia would be helpful. Thank you, everybody, for your patient listening. Thank you.
Thank you, Dr. Ikeda, for a wonderful talk. Any experience with the custom toric?
Sorry?
Any experience with the custom toric lens?
Yes, yes, I have used it. We have the Ultra Smart Toric from the Care Group, and it works pretty well, and they can customize it for you for even up to 10 diopters of astigmatism. It does work well for these eyes.
I had done one in about 10 diopters, and it worked actually quite well.
Yeah.
Thank you.
Thank you.
So much.